Every day, people just like you are searching for answers to feel better, live stronger, and finally understand what their bodies are trying to say. Here on PremierU Decoded, we uncover the science and the stories behind true wellness. From hormones and metabolism to the daily habits that shape your future. Because beneath every symptom is a message your cells are sending. And when we listen, we transform. I'm Brandon Williams, and together we're building health, hope, and confidence at the cellular level. Welcome to the place where better begins.
Welcome back to another episode of PremierU Decoded. And before we get started, can we all acknowledge that I'm back hosting the podcast today? Cue the music, because I feel like, guess who's back? Back again. Should be playing in the background right about now. That's right, Shannon Shores, back in the host chair. And this conversation is going to be fire, because today we're talking about something that has the power to completely change your health journey. Shifting. Not shifting your weight, not shifting your schedule, shifting your mindset. Shifting the way you think about healthcare, shifting from what you accept as normal, shifting the non-negotiables that you should expect from your healthcare provider. Because let's be honest, if your healthcare provider spends more time looking at the computer screen than looking at you, is that really healthcare? And if you've ever felt an appointment feeling more like the provider already solved exactly none of your problems, but somehow still managed to bill your insurance company, this episode is definitely for you. So Brandon, let's start with one question that might have both of us in trouble. Has traditional healthcare conditioned people to expect so little from the providers that they've forgotten what great healthcare actually looks like?
In brief, the answer is yes. And I think we should spend the rest of this podcast unraveling why that's the case. Because it's very complicated to understand what has happened in our healthcare system, what happens in research, what ways have we failed our modern medical society, and the way that the trajectory that medicine has been on. And it's complicated, but I think I can use a framework that includes clinical application that's going to make this obvious. Yeah. And I think that'll help us all move this narrative forward so that those watching this, including the providers as well, can better understand the system in which we're functioning, a different way to look at it, and ultimately so that we can all collectively ask for something better, because that's important.
So how did we get here? How did we get from not knowing what we're looking for to freewheeling our health on the World Wide Web? I think people are desperate and they're hungry for answers, and they're starting to realize that we're not getting it from our traditional healthcare system or what our insurance tells us what we need, right? Because even think about insurance for women, it's you get your mammogram at a certain age, you get your well women. For men, it's prostate. We've been listening to them and watching them dictate our healthcare, but now people are starting to wake up and realize, oh wait, that direction's maybe not for me. How did we get there, and how did we get so fired up? Why are we so fired up?
So I'm going to bring up topics that I want to pin and come back to. So these are things that I think will create inflection points for the remainder of the conversation. And they do revolve primarily around women's health, because it's very glaringly obvious to see that there has been a dramatic failure in the entire architecture of the system as it relates to female health. But specifically, I want to include things like cardiovascular disease for females. Mm-hmm. It's a very specific topic. I want to talk about neurodegenerative disease. Obviously, we will talk about, as a result, hormone replacement therapy. But many of these logical fallacies apply to men as well.
Yes.
And it's about an entire, I'll say it bluntly, as it relates to females. We know that females were not included in research studies until the early 90s, right? That's a dramatic problem. And if for people that don't understand that, it tells you how silly our system has been. But the reality is we have not moved far past that in the past 30 years. We still have a patriarchal, misogynistic architecture for our research complex. It still looks at females as smaller men. You cannot say that a female is a smaller man any more than you can say a child is a small adult. Everybody in medicine understands that children require very different approaches. They don't require the same kinds of medicines. There's very different applications. The dosing is dramatically different, but also the approach to the problem, because the biochemistry and the molecular cascades, the cellular biology, drastically different They are not the same. And if we refuse to see them as different and don't regard those differences, we will remain held back in our ability to move forward favorably, both for females, of course, but also for men and for children. We have to have an entire revamping, and I'm going to prove this point today, an entire revamping of how research is delivered. Thankfully, there are places in this country and in this world who do look at research in the way that it needs to be looked at. We have to get rid of this siloed treatment, magic bullet, diagnosis, symptom-based research platform. I'll take for example, this idea that I like to talk about a lot because it's a hot button topic and it is complicated, which is statins.
Okay.
This application of statins across the board, right? And apropos the comment about female health being basically just small men, right? We're taking data for females. The reality is this. Females present with a very different kind of cardiovascular disease often, and this is not something that's taught regularly. This knowledge has been around. It is known. It's in the literature. It's been heavily studied since the early 2000s. But the reality is 50% of the female population who presents with angina and who present for heart attack symptoms are presenting for a condition that is not related to plaque disruption and your standard stenotic model. It has to do with something called coronary microvascular dysfunction, which at the end of the day is an endothelial small vessel problem. And to look at it as through the same lens and framework that we look at, oh, you've got a plaque that might rupture, a zit that might pop and cause an occlusion of a vessel, you're going to miss the entire point. And you're taking half of our population and half of those people, so 25% of our population, and you're destining them for continued cardiovascular problems. It's why cardiovascular health is such a major killer for across the board, both genders. But we fail the female side of this equation from a simple failure to see it for what it is. This is an endothelial problem. It's a mitochondrial problem. Compound that, and I'll tie back in the statins part again. So now you talk about statins and their ability to improve cardiovascular outcomes. You'll hear this language, and I want to introduce it, which is major adverse cardiovascular events, or MACE. And everybody always talks about primary prevention versus secondary. Primary meaning you have not had a MACE, or you already have, and we're trying to prevent a second one, or a tertiary, quaternary version of that. If you look at statins across genders, they are not awesome at primary prevention. If you look at females, they're really not awesome. Very different. You can make an argument for males that they are favorable, and I will make that case today. There is a use case for them for both males and females, but it's not awesome in males either. For secondary prevention, it is, but there are superior agents that are also generic, that are really good for both populations, but definitively have been studied in the female population to be superior. Do have primary prevention characteristics, and they also just so happen to help with things like neurodegenerative disease, which is a commonly female-based problem. If we can shift the medical zeitgeist to looking at these problems this way and understanding this regarding how things actually present and not looking at research in this siloed way, we can move forward. But if we don't, we will always be 30 years behind. We will always be chasing our tails. And it's what we've been doing, and science is accelerating rapidly. And thank God, there are some really smart people I really like Dr. Isaacson, who is a part of he's a neurologist, and he's part of the Neurological Disease Associations, and he is pushing this narrative of we have to have better preventative health care. And he speaks the way that I speak about this, the way that we look at this as a practice. Thank goodness, because he's at a high level. He actually catches the ears and gets to have a voice on the stages that matter. And I hope there's more of him. And I hope that in our little micro bubble of the people that get to watch us, and then I hope that the message gets expounded so that more people can see this, that we can pull that curtain back and show people what's really behind it and give them a different strategy to move forward.
Yeah. Well, last week we hosted the M Factor 2. For a lot of folks, they don't know, that's a PBS documentary that Tamsin Fidel and a few others took as a passion project because she went through menopause as a broadcaster on air. right? And she was someone who did not have children. So she wasn't looked at kind of that from that hormone perspective, women's health, because it's really about women childbearing. Outside of that, there's not a whole lot of support, right? That's when they see us, and that's what we have. And talking about the cardiac piece and the cognitive piece, what resonated with me after watching that and what I heard you say is what I noticed was working in silos. What they talked about, they definitely walked back from the Women's Health Initiative and said, my bad. Yeah, the information wasn't quite right. We're sorry that there's a whole generation of women who didn't get the hormones that they needed. But as we see that elevating number of rate with heart disease and dementia for women, I say all this because in our event, which over 150 people, it was amazing. Women are hungry for this information. We had little community tables, and one of the tables was the Alzheimer's Association, right? And as it was so interesting afterwards, I spoke to the lady to tell her, thank you for being there. And I said, tell me how many times at your chapter level are how you guys talking about hormones related to cognition, related to Alzheimer's, early on dementia, maybe, again, not this is going to cure it, but is there a way that as we slow down, what's the effects of this whole generation of women who didn't have hormones, and how are we seeing that contribute to these numbers? And what she said to me is, this is the first time I really heard it and thought about it in that way, which was surprising to me, but not surprising, right? I'm going to say surprising, but not surprising. And then a few days later, I said to her, I saw her just by chance, and I brought up this conversation again. And what she'd been thinking about since that conversation was, what about the women who have early onset dementia who are now just gaslighting themselves by saying, oh, it's just perimenopause. Oh, it's just menopause, and not getting that early research.
Right.
So how is it, and when you hearing that, is that talking about working in silos, how do we move past this so all these disciplines come together? Because we have been thinking about it as these lanes versus a complete interstate for our health. And if we're not thinking about it like that and getting all those different information, the healthcare system is surely not going to provide it to it in that way.
Right. Well, I see part of it has to do, let's just be honest about this. For research, I worked in research for many years at pretty high levels and have worked for some brilliant people. But the setup and the framework of research is, let's just be honest, it's based off money, right? And to no offense, there has to be money to run these labs.
Yes.
But if you talk to somebody who, let's pick out, again, a lipidologist, because there's a lot of money for cardiovascular disease. So they're a good example of this. I have heard from a lipidologist, if I do a study that are based on statins and statins' ability to primarily or secondarily prevent MACE, I'll get $20 million. Snap, boom, easy. If I'm trying to look at an intervention such as dietary change, exercise, lifestyle factors, or most other things, I will do my best to scrounge up $500,000. But they have 30 hungry mouths that work in their lab. They have expensive equipment. They have bills to pay. People looking at them, what are they going to choose? You're going to continually choose that because we've created this financial incentive to continue down the same path. So there's that. But also, you're always going to see a fracturing of this idea that we can take a single agent and treat something as complicated as cardiovascular disease or Alzheimer's, right? There's good data about, one of our favorite things, GLP-1s. Good data about GLP-1's ability to stave off or reduce both symptoms and delay Alzheimer's, because Alzheimer's is ultimately a metabolic disease if you boil it down. However, that is not shown to be as robust in preclinical models, and here's why. It's far too complicated. And if you take patients that are too far along, I make this correlate all the time with Alzheimer's and the presentations of memory loss and those symptoms that really, if you ultimately look back, have been brewing for 15 years. And they come to a head. Reversing that, getting that train to stop is darn near impossible. It's like diabetics, right? We see patients all the time, and we talk to them all the time who are insulin resistant. It is 10 years before they become pre-diabetic and 5 years after that before they become diabetic, right? And if you can take that insulin resistance model, you can shift it. I won't use the word cure. You just correct it and they don't become diabetic, but you don't cure diabetes. Type 2 diabetes is not curable. You can manage it, but anybody who says they can cure it is wrong. You can manage it great. The A1C, the glucose-centric model can be corrected for that, undeniably, but you did not cure them. They are always still dealing with that for the remainder of their years. Why do we let patients get that far before we intervene? It is illogical. It's not scientific. I get so bothered by follow the science. Well, science is not settled. Science is always evolving, as it should be. If it's settled, it's not science. You're in some other forum, right? Science's endeavor is to constantly test and question.
Yes.
And we have to have a fundamental change of how do we test and question interventions for things that are complicated. One of the other, I like analogies. One of the other things that I think about this problem, like with Alzheimer's, like with diabetes, cardiovascular disease, is this. I'm very curious about the people who do this for a living, but let's imagine we're all at a ski resort, right?
Okay.
We're next to this beautiful mountain. Well, on those mountains, there are people, and God love them, who understand the chemistry of snowfall, the temperature, barometric pressure, the situations that are likely to create an avalanche. And they are on that mountain risking their life to try to prevent an avalanche from crushing the resort and all of its occupants.
Yeah.
Same deal, because they know that once that avalanche is let go, they ain't stopping it. It doesn't matter how big a wall you put in front of it, it will keep going, depending on how far advanced that avalanche has gotten. And we have gotten into this system where we're like, let's put up this really strong fence somewhere down the mountain and we'll stop that avalanche. That's dumb. That's not how this works. You have to be on the mountain looking for the subtle signs for where they are well in advance of when that avalanche happens. And until we shift towards that and we let go of this, we're going to study this drug, this singular intervention in isolation to prove that it's okay for the FDA to get safety and efficacy so we can get an FDA approval so that insurance will cover it. We're always going to be stuck in this problem.
Yeah.
That has to change.
Well, we're talking about shifting, this episode all about shifting and thinking about healthcare and insurance, right? One of the other things that I know at our new facility we're going to bring on and was discussed in the M Factor 2 documentary is a DEXA scan, right? This is not a new tool,
no,
right? And talking about insurance, how old do you have to be to have a DEXA scan cover? Like 65, 60, 65? And what we know is, and a lot of people are probably like, what's a DEXA scan, right? But what we know is that by the time you're 60, 65, that's too late to have a DEXA scan and say, oh, now you have osteoporosis.
Right.
You know, your bone health is gone. The avalanche has happened, right?
Yep.
So how do we start now to shift and think about how do I get these tools, these advancements? How do I have these conversations prior to it being too far gone? And then now it's happening. They're just pumping you full of meds or those sort of things. We have to shift because these things are out there if we know about them. And how do we get ahead of it before the avalanche takes us down the mountain?
Yeah, you just said it, which is to incorporate these tools earlier, more aggressively, and in advance of the insurance paradigm. Let's just face it. Insurance is there for catastrophic problems. Historically, that's where insurance came from. We've gotten accustomed to, and I'm not saying inappropriately so, but we have become accustomed to as a society that insurance covers every facet of our healthcare. Insurance is not there for that ultimately, and that's glaringly obvious.
Yes.
Insurance is there for catastrophic problems. God forbid you get cancer. God forbid for you have some serious trauma that you need to be hospitalized for literally anything. Insurance is awesome for that. It's a lifesaver to keep you from going into bankruptcy, right? But that's what it's for. It does not deliver health. And anybody who doesn't choose to see it that way, tell me how much healthier you are by letting your insurance dictate your care. I guarantee you will not be healthier. If you can choose to use these tools, and often they are not covered by insurance, but eventually, if enough of us get pissed about this. And if enough intelligent people start to see this problem for what it is, that will change, right? The masses will win, but we have to have enough intelligent voices who look at this problem for what it is and don't just sit back and be like, well, that's how we've always done it. We're just going to keep doing it that way. Or I've got to keep having this paycheck, so I'm going to abide by this old broken system. We can't have that.
Yeah.
That just needs to stop.
Well, I've heard people say, well, I'm paying for it. I paid his insurance premium. Is going to use them. Yeah, no one likes going to the doctor and you're not doing it. So it's sick. We talk about this all the time. It's sick care versus well care. And what is well care? Well, that costs money. Yeah, it does. We spend money on lots of things, right? We spend money on essentials, but non-essentials. But why is it when it comes to healthcare, people think, oh, I have to pay out of pocket for this. And this is that shift we have to make. We would do this, what do we put into our cars or our homes or, God forbid, what we spend on our children at a drop of a dime. But when we're now thinking about, oh, how much is that? Do I have to cover it? Does my insurance cover that? We know that when people ask, does my insurance cover that? I almost flinch when people say it. Is it important to you or not? Are you going to let your insurance company tell you if it's important? And if so, forget about it.
Yeah.
You have to decide what's important for you.
Right.
You have to decide, are you willing to invest in yourself? Because here's the thing, especially thinking about bone health now and all that's coming out, I don't want to find out too late. I have to invest in my 70, 80-year-old self now at 48 years old. I can't wait till I'm 60 and all of a sudden now my hip's broken. What do? I have to do it now. And if I'm not willing to do it now, I better save up my money and have a really nice nursing home in my future that's going to take care of all my bougie needs because I got to decide.
Yeah.
Do I do it now or do I do it later? I don't know about you, but I want to invest in it now because I still want to be tap dancing when I'm 80, not in some bougie facility that hopefully has good wine from California, not some box stuff, because Concord grapes here in Missouri are junk. Just sorry.
Yeah. Well, and what you just described, so a simple way to make that applicable to people that they can understand is to look at this as a 401k.
Yeah.
You're creating this reserve of your health. You're going into those years with as much muscle mass and cellular reserve, cellular energy, and low inflammation state as you can, which is going to carry you through. And it's going to allow your health span to be better, your quality of life to be that much better. It would be like saying, I'm going to wait to invest in my 401k until I'm 64. Right? But I'm going to retire next year. They'll say, well, that's fine, but you're not going to do much with that, right? Or afterwards, where you're already spending money and you're underwater, like, well, I can't put money into my 401k. Right, because you've run a deficit.
Yep.
It's no different. Now, in a 401k, you get accrual of interest and, there's old taxes or whatever. So that is different. It's not a perfect analogy, but it does make logical sense that you have to buy as much of that as you can. And the video, I loved this M Factor 2, the before the pause, because this is where we can make true actionable change. Menopause, undeniably important. And I want to go back to the cardiovascular and Alzheimer's part of it because the hormones come into play here. But this perimenopause idea and shifting the idea of how we see perimenopause and menopause, I want to stop using these reductive terms. It bothers the crap out of me when we use these lighthearted phrases like hot flashes and brain fog. Let's call it for what it is. It's a pathologic disease state. That is hot flashes are a hypothalamic thermogenic dysregulation. It's a neurologic disease. Yeah. It's not a hot flash. That's reductive. And as a result of us continuing to use language like that, we will continue to hold females back. And it will not be regarded as the serious problem that it truly is. Brain fog too, like, it's just brain fog. Well, that means lots of stuff. It's a neurologic disease though. It'd be like saying, oh, you got crushing chest pain. Oh, you've got an elephant on your chest. Isn't that cute? No, we would think that's dumb, right? We would know, you didn't go to the freaking hospital right now. You've got a huge problem, right? And these aren't hospital-based problems, but you understand the point is to say, let's change our language about how we approach this problem because it's not simple, it's not easy, and it starts early. It starts wrecking lives early. The earlier we intervene and the more we get behind this, the more we make this tidal wave of, no, we're not going to put up with this anymore. we are going to make a sizable change in how we are cared for in this country and across the world. I am purposed with this idea. This is what drives me and makes me want to understand and why I'm capable of learning super complicated things, because I understand that this problem requires complicated think. And I just happen to enjoy solving complicated puzzles. And the more I can be passionate about this and make others passionate about it too, I think that that will make a difference. And that's what my fingerprint is here, is that it's what our fingerprint is.
Yeah.
We are trying to deliver that level of care, this change in ideology about healthcare and the delivery of healthcare and how to take care of patients and how to shift that narrative forward 20 years, because it's so very far behind. We've got 2 big ivory tower institutions who are in this town with us, and both of them fail us regularly. I'm not saying that all the researchers that are there are a problem. Who I respect are that we have several patients who are primary care providers, right? And I just saw one last week, and he was like, "Man, what you guys do is awesome." And I said, "What you do is awesome. I can't see 35 people and keep my sanity. I sure as heck can't do it well. That is not how I function. God love you. And I don't blame you for not being up on the very cutting edge of this research. How could you be? You know whose job that is? The people in the ivory institutions, the people who run your societies and should be telling you this information and making these sea change moments for you. Every year that you go into your meeting, they say, you know what? We've been screwing up for the past 30 years. We're going to change this. And next year, it's the same thing. We fixed this now. Here's how we do this. Making sizable changes incrementally every year. And they're not doing that either. I hold them accountable for this problem. It's not the people who are doing their best just to take care of patients, because they are drowning in patient visits. They cannot possibly keep up with this. They're doing their best. They're reading the literature, but if the literature sucks, I read studies constantly. I'm pretty darn good at it. And it still takes me a long time to digest that information and make it actionable within our framework. And that's with me having the benefit of being able to scale back how many patients that I see and to be able to look at these complex problems in a more detailed way. So I give them credit. I give them a grain of salt. Every time I hear, well, my primary care, this, that, I'm very cautious. I was like, they're doing the best they can.
Yeah.
But this is why we're here. We want to work as a collaborative team with your doctor. They're doing what they do. And if you want that healthcare delivery from the insurance model, they got you. They're awesome at that. Guess what? We've got everything else. And we've got all kinds of really cool things that they don't even get time to think about. And we can figure out how that can get married and utilized to ultimately improve your health.
Well, what I love about what you said, though, is that we have to, 1, advocate.
Yep.
Number 2, understand, right? Because here's the deal. One of the concepts that came through the M Factor 2 was this, I don't feel like myself, right?
Yeah.
It was, the letters are on there. It was across the screen. And I think it's one of those things when you show up to your primary care physician and they say, I don't feel like myself. They run the blood work and they say, you're normal. We hear this story all the time. And they say I'm normal, and you walk away. Again, they had a small window to see you. The criteria for that visit was probably outlined of what you could cover and what you couldn't was be covered by that insurance.
Mm-hmm.
Walking away and just settling when you still don't feel like yourself, I'm sorry, is on the person too. You can't just say, because they're doing the best they can.
Right.
They gave you that information based on the tool that was there. But you, if you still don't feel like yourself, you have to ask for more.
Mm-hmm.
And it's having the real conversations. I think that's why people are kind of diagnosing themselves and starting supplements wildly. Peptides from unknown places because they know that, but they don't know who to go to.
Right.
And I love how you said about how we say things like hot flashes, right? Or the brain fog, and how those are serious, because women tend to do that. Yeah. We tend to just say, not us, right?
Mm-hmm.
We're okay. We can push through it. The one scene in the documentary, that woman said, they went to ask me my name. Mm-hmm. And I didn't know it.
Yeah.
How can we make that just such a, that happens. That's just having early dementia.
Me too,
That's
girl.
senioritis. Me too. I get it. But as a child, I watched my grandmother in the stages of dementia, and how I would describe it. I'm not a PA, I'm not clinical, but as a woman, as a social worker, as a person on this planet, right? I can tell you how things look and how they feel and things I've experienced. I watched my grandmother through that cycle, and it was almost as I would describe it as, like a metal filing cabinet, and you'd have the button on the side, the old ones, and you'd pull it out. How I always thought about my grandmother's brain was that in the midst of trying to open that drawer at first, it was opening the drawer and her brain was trying to pull out that file, that memory from 1982 or that recipe that she knew off the top of her head. And she'd go to get that file out and all of a sudden the file was empty, right?
Yep.
It's been there a million times. And then what was happening, I could see her brain would start to pull that file out and the file wouldn't come out at all. And then the drawer wouldn't open, right? All of a sudden, all those memories, all those things that she knew, her life that was there was locked in that file cabinet.
Right.
And I can tell you something is that one of the memories that I will remember the most was the day that my grandfather passed. And at that state, she didn't know who anyone was. She didn't know who we were. She didn't speak. She could not feed herself. Even mobility-wise, her body was starting to slump, right? She was just existing.
Right.
And the day that he died, the nursing home, had an ambulance, bring her in on a stretcher and go and lay her next to him. And a single tear dropped from her face. She knew, but that filing cabinet, right, locked up on her.
Yeah.
And I think when we think about cognitive issues and how we dismiss it, and I think that just hit me so hard when you talked about how we just pass it off, because that's what women do. But to actually watch that disease state happen is that we can't dismiss it anymore. If there was something we could have do, not trying to say we're solving all these things and all the cures of this, but anything we could do to delay that state, to give her better quality of life, her or anyone else, why would we not do it? And we're far enough along in 2026, I think, to say we need more.
Yeah.
Because we can't let our brain that is so important to us, we can't just pacify and say, this is just what happens as we grow older. There has to be more. And we have to ask for more and not just settle for what's given to us.
Yeah. And, we're losing out as a society as well because you're taking half of the population, a very intelligent half of the population, actually, let's be honest, and asking for them to lose, we're losing wisdom.
Yeah.
Because those years spent with declining mental function, with mild cognitive impairment, these things that progress to more advanced, we are losing high-functioning individuals with lots of experience who have great wisdom to pass on and could make a major difference in society who are out of the game.
Yeah.
Because they're not available to be that anymore. And that is a disastrous problem. And it is something that needs to be corrected. If we as a society want to move forward and get better, this is one of those major strategies. How do we keep those individuals sharp as a tack until the day that they decide, like, I'm going home, I'm out of here? That's super important. And we need to all endeavor to figure out a way to do that. And it's interesting to go back to the M2, the second M Factor video. So Dr. Mosconi, who also works at the same place as Dr. Isaacson, and I believe that they are working together on this endeavor because she's looking to move the Alzheimer's risk for females down to the male risk, which would be a 10% risk, ultimately, a 10% reduction as well, because women are much more likely. 70% of Alzheimer's patients are females, right? She's looking to take that risk and make it equivocal. I think that job is actually going to be probably fairly simple. Simple in this is how we do it. Because there are major disruptions for females that happen around this time that have to do with hormone fluctuations. And if you look at, again, Alzheimer's as a metabolic disease state, to make that more clear, for those that don't know, there are these genetic propensities towards this called ApoE. ApoE 2, 3, and 4. 4 being the worst, so to speak. If you're homozygous, meaning you've got 2 copies from your parents of ApoE 4, your risk of Alzheimer's disease is very high. what that does to you, the reason it makes you susceptible to Alzheimer's disease is that it creates a cerebral or brain-based insulin sensitivity problem. It makes you prone to getting insulin sensitivity or diabetes, but let's just call it insulin resistance within your brain, well in advance and exclusive of it happening in other tissues. That's how that genetic propensity and that phenotype expression causes that propensity in humans. We have to see it that way. Guess what estrogen does? It helps to improve cerebral insulin sensitivity. That's gone, right? We're wondering, like, I wonder why there's this female predilection for these truly metabolic diseases. Same thing applies to the cardiovascular disease. If you look at coronary microvascular dysfunction, and that doesn't comprise all of it, but it comprises 50% of female health consequences related to the cardiovascular system. That's a sizable number. That is an endothelial problem. Guess what estrogen does? Estrogen helps to improve endothelial function and nitric oxide production. And I would love to go into tetrahydrobiopterin, BH4, and how that system works because it's fascinating and it gets ignored. But there are simple amplification points that we can create for patients that mean that we can actually treat that problem for them. But estrogen being a primary of those. And we know that that hormone is lost. And once it is lost, it's gone.
Yeah, it's not coming back.
Unless you give it back, right? And this, I'm going to be mean for a minute. So, I know this is not going to surprise anybody. So this idea that in medicine that we were concerned about hormone delivery to patients, to female patients, right? And for the WHI, whatever. Like, don't get me started about that. Everybody could have read that data. And yes, the black box warning was removed. Congratulations. Thanks for joining the club, bub, right? Like, thanks for catching up. All of those doctors who refused and still refuse to prescribe those medications because of that statement are weak and they're lazy. They could have read it like the rest of us and known that that was bullshit.
Yep.
But they didn't. They were waiting for their society to say, their medical society to say, it's okay. You can use these. In the context of those same doctors, I guarantee you will argue that it's okay to prescribe adolescents and 20-somethings and 30-something-year-olds synthetic hormones, birth controls, which we know have carcinogenic potential. We know this. This is, I was going to use the wrong phrase. This science is well known. What's the difference?
Yeah.
You're okay with that, but you're not okay with something that mimics bioidentical versions of this? You're dumb. I don't have anything else to say besides you are ignorant. Catch up. If the provider has a problem with that, find a different one.
Yeah.
I'm sorry. They can't be salvaged. That is an idiotic, ignorant, misogynistic viewpoint because you're okay with destining certain individuals with all of these problems based off because your society said it was okay or that's how I was trained to do it. Get over it.
Yeah.
I was also trained to do all kinds of stupid shit that I don't continue to perpetuate in my clinical practice because I know they were wrong. I have undone that, as we all have. We attract people to our practices who look at the world this way and are willing to buck the system because we understand that the system does not function to help us be healthy. So sorry for the rant. But
I love it. Because you're talking not only about us shifting, but again, as a culture shifting, the medical system shifting. Because I can even tell you from, working at PremierU, and a lot of people see me just as an advocate for women. I love rallying women to get out of their own way of their own success. Yeah. But I tell you, like when we were putting together the M Factor 2, I was putting out like social media every day. I do not want to hear from you. I can't go to this to learn about my health because little Stevie has a baseball game. Little Stevie has practice. Guess what? You know what? I'm mom of 2 boys. I'm in a different era. My boys are older, but I used to have to run them around. I understand that. But I am so tired of women saying how busy they are that they can't take care of their health. Because this is what I said to them. Guess what? When you wake up in the middle of the night and you can't sleep because you have 47 tabs open in your head, guess who's going to be sleeping like a baby? little Stevie. I don't want to hear it anymore. I'm tired of the whining. I'm tired of the complaining. I'm tired of people, even when they see me, what do you think about this? Does PremierU do this? Come see us.
Yeah.
And if my doctor doesn't do this, why not?
Why not?
And if you don't like it about your doctor, find somebody else.
Right.
I'm tired of that insanity, right? I mean, the definition of insanity is doing the same thing over and over, looking for a different result. That doesn't happen, right? Because it continues to do that. So even in my female circle, I was very direct. I'm sure you're surprised.
We're all,
you're all surprised.
Yes.
That I was very direct of, if you're not here, if you don't have a good reason why your butt's not in that seat for that event,
Mm-hmm.
I don't want to hear another whine, complain, question, because I'm taking care of my health and the people I love. I hope you're going to do it too, but we can't be dismissive with our health anymore, because if we're not willing to do it, no one else is coming to save us.
Right.
We have to be our own advocate. We have to push. And we have to have the people who are not lazy, who just say, this is what the protocol says, right? Or this is what I was told. Because I love when you get fired about the Women's Health Initiative. Why did we even accept that? How many times in the world are things said and people go, I'm not listening to that. I'm not doing that. But this one freaking study comes out and all of a sudden it's like, woo!
Right.
And it's still out there. That narrative's still out there. We hear it every day, where even though they've come back from it, the black box warning, people are still practicing that way.
Mm-hmm.
Or what I love is like when they have been on it and having great hormone success, great success from their hormones, and they get to be 60 years old and they go, we need to take you off of that because it might cause cancer.
Right.
What?
Right.
And so how do you answer that, right? These people who are listening say, oh my gosh, my provider was okay with it until I turned 60, 65. We know that they need it. Why are they doing this?
Yeah. My answer to that is find a different one. I mean, I've asked a simple question before because I had, it bothers me that because of my perspective about how I feel providers should have been looking at this problem as scrutinizing individuals. I believe that doctors go to school to take care of people because they care about them. Some go for money, whatever, or fame, whatever. Most of the time, it's because they care about humanity and they want to give back.
Yes.
And I truly believe that they're not bad people trying to do bad things. I think they get stuck in this system. They become weak and lazy.
Yeah.
And they don't endeavor to continue to learn. Here's my problem. So all of a sudden, this black box warning comes off because the magical 3-letter agency said it was okay for us to use these now, when the reality is it's been fine the whole time. And they say, okay, we can do it now. Why would you trust them with your care? If that's the kind of person who's prescribing these, they don't know what they're doing. They have not been doing it for years.
Right.
They clearly don't have the right perspective about how these work.
Mm-hmm.
And they're just acquiescing to, well, I guess my patient wants it, versus being passionate about saying, no. You don't want this. You need this. This isn't, it's an option, because healthcare is always an option. You can choose, and there are individuals who cannot use traditional forms of BHRT.
Yeah.
Obviously, there are exceptions. There are options for those patients, however, to help them feel better. It may not look the same as X, Y, or Z person.
Yeah.
However, there are many ways to look at this, and that you have to be well-versed in how this is used and just basically say, no. This is an option, but it's imperative.
Yeah.
Because it matters. And part of what bothers me about research and this viewpoint of holding back, outside of being pissed because they would hold back female care advance, it also holds back men's care advance as well. And that's the dumb part of the system. Like, yeah, okay, let's just say you are completely misogynistic and you only care about the male species, the male version of this species. You're holding them back, because guess what? We define gender-based differences. It helps to move forward the narrative of what's really happening here, right? That advances science to know, because there are always problems like we don't know fully everything about anything, right? There's always more to learn about said disease state, and it could be better. We could care for it better, right? And one of these days when we start using CRISPR-Cas9 and prime editing, DNA manipulation, we might solve some of this stuff, and that is coming, but it isn't now. And those treatment strategies will be very different. that looks very different. But we have held back men too.
Yeah.
As a result of this refusal to incorporate the female gender. And how does this look differently, and what differences are created in this physiological process? It's illogical from so many fronts, it's not even funny.
Yeah. Well, I told you this segment was going to get hot. And I don't know if it's because Brandon has his glasses on. He brought his studiousness.
Yeah, full nerd mode. Right?
We gone full nerd mode. It's
still
hot.
me. Look, see, still me. I promise.
Yeah, still him. I love these fiery conversations. We talked about this very early on. As we wrap this up, Brandon, is there anything that we didn't cover, or if there's a parting line that you want to leave this audience, because we've got them fired up, right? You started with some of that nerdy, scientific stuff, right? To set the tone. You started with the edumacation, right, of them. And then we got into some little controversial. We both get very passionate about this topic from two different perspectives, right? And now we're going to land the plane, right? So what is the thing that you want this audience to walk away from this episode of Decoded?
If I have to leave a sentence, it's this. Stop accepting inferior care.
Yes.
It's as simple as that.
Yes.
Now, finding superior care isn't always easy. Obviously, I'm biased and think we do an awesome job of it. But not everybody's near us or don't have access or whatever. But in simplistic sense, stop being okay with this inferior care. And I think a lot of people don't understand that it's even happening, but now you do.
Yeah.
I just made very clear examples, and Google it, check me. You're going to find that I'm right.
Yeah.
And it should make you mad. And I want it to move your health journey forward.
I agree with that. And I think my parting line for women is that the I don't feel like myself, if those letters resonate with you and you're tired of being tired, you're tired of not showing up the way that you feel like you used to, do something about it. Don't let the world tell you. You tell the world, I want to be better. I want to be sharper. I want to feel like fill in the blanks. Don't wait for someone to save you. This is your time to find that person. And if it's not your provider, as you always say, find a new one. And this is what Decoded is about. It's about having those conversations that no one wants to really talk about. It's bringing the science, but it's also bringing the reality that healthcare is shifting, and we have to shift with it if we want our future self to look back at this moment and say, they did it. They weren't lazy with their healthcare. They found it. So thank you so much for this episode of Decoded. I love being back in this chair. I love having these conversations with Brandon. He can really educate me every time he says something that I'm thinking in my head. Pin that, go back and Google it, or ask ChatGPT, what was that really meaning? But this is what we do. We uncover, we decode. Thank you, and we look forward to the next time.